Uh, Thank you. First, congratulations for the successful, wonderful summit. Mr. Chairman, dear audiences, may I please present the updates of the superficial veins thrombosis? It's by definition thrombi within the superficial veins that partially involve or occlude the lumen and causing inflammatory reactions along the course of the vein, mostly occurring in the lower limbs, affecting 3 to 11% of the population, and recently reported that USA presented 123,000 cases per year in a latest publication in 2019. The association is what really matters. It is associated with 40 to 60% DVT, 20 to 33% asymptomatic pulmonary embolism, and 2 to 13% of symptomatic pulmonary emboli. Clinically, it's simple that we feel a palpable cord with firm areas that is hot and inflamed and follow the path of the superficial vein. However, it can be associated with immunological syndromes like Trousseau, Lemierre-Mondor syndrome, and inflammatory diseases such as thrombophlebits, obliterans, or thrombophilia. It is also caused by trauma or by injection of irritants, and it may be a complication of lower limb varicose veins. Clinical diagnosis tends to be straightforward, but supplementary tests are directed towards extension and thromboembolic complications. In recent meta-analysis, the mean prevalence of 18.2% of DVT and 8.2% of pulmonary emboli among patients with superficial vein thrombosis. So, in a couple of questions, the updates are: what is the most appropriate terminology? It is the superficial venous thrombosis rather than the superficial thrombophlebits. And this implies that there is no role for antibiotics. It also implies the misconception of being a benign disease. Second, what are the etiologies of the superficial vein thrombosis of the extremities? Vercous red remains the cornerstone. Varicose veins is related, and non-varicose related, you have to suspect malignant disease, thrombophilia, and estrogen intake. Iatrogenic factor is of paramount importance because it damages like in intravenous injections or intravenous solutions, caused during castrations or hemodynamic procedures, and of course the new procedures like endovenous procedures of laser radiofrequency and sclerosant materials, and drugs like chemotherapies agents also induces superficial vein thrombosis. When should thrombophilia be investigated? Thrombophilia should be thought about in unexplained superficial vein thrombosis in non-varicose vein patients. First manifestation of superficial vein thrombosis in 11 to 15% of patients with protein C and protein S deficiency, and in 40% of factor V mutation. However, there is no data to suggest that thrombophilia changes the rate of superficial vein thrombosis recurrence or progression. Routine testing of the superficial vein thrombosis for thrombophilia is not recommended. They are recommended also only in the following status: whether there is unexplained superficial vein thrombosis in non-varicose vein patient, in cases of progression despite adequate anticoagulation, younger people less than 40 to 45 years, recurrent venous thrombosis or superficial vein thrombosis, unusual size like mesenteric vein or cerebral vein sinuses thrombosis, unexplained neonatal thrombosis, skin necrosis caused by coumarin or warfarin, arterial thrombosis before 30 years of age, related patients with post-thrombotic abnormalities, and patients with a clear family history of DVT, also unexplained prolonged activated partial thromboplastin time, and recurrent pregnancy loss. The fourth question: is there a concomitant relationship or correlation between the superficial vein thrombosis, venous thromboembolism, or what are the risk factors? Thrombotic involvement of the great saphenous vein, particularly close to the saphenofemoral junction in cases of varicose veins, that's high incidence of DVT and pulmonary embolism, level 1B. Superficial vein thrombosis less than 3 cm from saphenofemoral junctions involve risk of pulmonary embolism and risk to DVT, level 2B. Varicose veins does not increase the risk of venous thromboembolism, although it is related to the increased recurrence of superficial thrombophlebits. When should investigations be used? What investigations should be used? The cornerstone lies in the duplex investigations. Others are guided also to detect pulmonary emboli if and when they occur. Cancer screening is of paramount importance in non-absence of varicose vein or extensive superficial vein thrombosis with or without DVT or pulmonary embolism, or when recurrent or idiopathic superficial vein thrombosis occur. The last question, when to indicate clinical treatment and when to indicate surgical treatment? The objectives are to alleviate symptoms and prevent thrombosis extension, avoid recurrence, and prevent thromboembolic complications like DVT and pulmonary embolism. In presence of varicose veins, if it involves the arch or the deep venous thrombosis, anticoagulation is initiated. In cases of deep venous thrombosis, the deep venous system is not affected. We have, whether a short saphenous trunk affection, we anticoagulate for 7 to 10 days, and if surgery is needed, it could be done afterwards. And in case of collaterals, we can go for surgery. For the non-varicose veins, whether it affects the leg or the thigh, if it affects the leg, elastic compression and non-steroidal anti-inflammatory drugs. If it affects the thigh, we can go for whether it's an lower or upper 1/3. If in the upper 1/3, due to proximity, we can go for anticoagulation. If the lower 1/3, the repeat assessment after 1 week. If the patient is stable or progressed, in case of progression, go for anticoagulation, and if stable, maintain clinical treatment. How should the clinical treatment be conducted? Don't have a thrombus involvement, or for patients who don't have saphenous involvement or arch involvement and not increase clinical risk of DVT, we can go for rest local compression, heparinoids, and non-steroidal anti-inflammatory drugs and elastic stockings. This is level 2C. But anticoagulation is preserved for those with arch vein affection, extension exceeding 5 cm, thrombotic risk for any reason, or deterioration in the follow-up of 7 days. The elastic stockings by themselves only are not sufficient, but just 1 minute more. But when combined with other treatments, it accentuates the clinical improvement. For the heparinoids, they provide only local relief of the symptoms and reduce the local inflammatory process and the intensity of pain. Non-steroidal anti-inflammatory reduces the recurrence and reduces the area affected, but they are inferior to heparinoids. Anticoagulation, less than 3 months. Enoxaparin for prophylactic dose, it is not bad, it is equivalent to a therapeutic dose. The DOAC have shown in the surprise trial to have a non-inferior effect to enoxaparin. However, they remain an off-label use for this medication. Lastly, the surgery, venous ligature with disconnection and elastic stocking, similar results like low molecular weight and elastic stockings. Saphenectomy and venous thrombectomy may be indicated to reduce the extension and provoking difference.